Well done for those of you that have made it. Extricated yourself from fabric or wherever you were last night and managed to get here. So I'm going to talk over the next sort of 25, 30 minutes or so about encephalitis, and I've not entitled it infectious encephalitis because, let's face it, we all know infectious encephalitis is really what is important. I'm director of the Infection Neuroscience Lab, so we're physically based in Liverpool, but we're a really international group that do a lot of work spanning the whole translational spectrum, from basic in vitro and in vivo modelling work through to analysing biosamples and neuroimaging, and through to working with policymakers, particularly the WHO and the Academy of Medical Sciences, to try and really push forward our investigation and management of patients with encephalitis. And this whole talk really, this whole session is a consequence of the feedback we had from previous years, which was that a lot of people work in vitro or in vivo models of encephalitis, or they might work in social sciences or rehab or policy, or they might even be clinicians who haven't seen that many cases. And there was a real feeling that we ought to couch the entirety of the conference in the kind of clinical concept of what it's like to see a patient at the front line. If you're bored on your train or plane home and you'd like to hear more about this, I think if you stick my name and brain into Spotify, you'll probably find one of my interviews, and here's an example of one of them, which gives you a sort of the whole story, but I'll give you a synopsis here. So encephalitis is brain inflammation. It's not encephalitis, it's encephalitis. We created the language, please respect that. But it's a brain inflammation problem, and we think of it largely being infections, there's an example there on the left, or antibody-mediated, which is very rare and very unimportant, but I think Sorocha's going to babble on about it afterwards. And then there's about a third where we never find the cause. Of the infectious causes, they're often viral, or bacterial, or fungal, or amoeboid. A lot of the work that we do when it comes to seeing patients is based around the Association of British Neurologists and BIA national guidelines we produced, in fact, a decade ago, in which we're currently updating now. And it's really important when we think about this sort of condition to make sure we're working with our colleagues who aren't in the neurosciences field, particularly those in intensive care and those from a nursing background. So how do you manage a patient with encephalitis when they present to you? Well, there's very helpful algorithms like this one that Mia and Arun from Johns Hopkins put together, which make it very algorithmic, very sensible. Basically, the patient comes in, you check if they're breathing, you do an LP, and you give them acyclovir. But then you turn to the textbooks, and this is the array of causes of infectious encephalitis that you'll typically be confronted with. Is it a togaviridae, a flaviviridae? Is it a picornaviridae? Is it a coronavirus? Is it herpes viridae? And somewhere between these very simple algorithms and these very complex textbooks, we need to know what to do for the patient in front of us. And this is the patient in front of us. So here we're presented with a typical patient. So he is a young man in his late 30s, early 40s, who presents with a fever or a flu-like illness and then a headache. And he's a bit confused and he seems a bit muddled and he's just not quite right. Now, this is the fairly typical initial presentation of a patient with encephalitis. Now, having done this for a number of years, I can tell you that these are the thoughts that go through the head of a junior doctor, as I was not that long ago, on the ward. They're thinking, well, okay, they've got fever or a flu-like illness, they've got some sort of brain dysfunction, they're being a bit weird. Could it be a urinary tract infection? Or maybe it's pneumonia. In fact, maybe it's diabetes or some sort of hyperglycemic problem. Maybe they've taken some drugs, maybe it's alcohol. Maybe if they've got some focal neurology, like a speech disturbance, they might think, well, could it be a stroke? And then in the older patients, is it just delirium in someone that's older? And I'm indebted forever to Nick, who's supported me for many years, and also as a keen medical historian, for putting me onto this Mesopotamian text from the 7th century BC. So if junior doctors don't know it now, Mesopotamian junior doctors knew it then. This is what they called brain fever, which is a headache which roameth over the desert, blowing like the wind, flashing like lightning. It standeth hostile against the wayfarer, scorching him like the day. Like the one with heart disease he staggereth, like the one bereft of reason he is broken, his eyes are full of cloud. It's beautiful, right? They had no idea what a bacteria was or a virus back then, but it's a beautiful clinical description. It's a condition which presents typically with sort of a headache. It travels across the desert, across regions. It hits you suddenly like lightning. It's hostile against the traveller. Think about their travel history, wherever they've been. Scorches him with a fever. It causes ataxia and confusion. He's bereft of reason, and he's got an altered mental status, and his eyes are full of cloud. Right, that's beautiful. They knew it then, we should know it now. The problem comes because, of course, headache is hugely common. Fever is hugely common. Confusion is hugely common. These people rock up in the A&E, and yes, some of them will be UTIs or pneumonia or drugs or alcohol or something else. And what we did to try and understand how to digest this was really say, well, look, if someone comes in and they're started on the hospital's antibiotic regime for meningitis or their antiviral regime for encephalitis, how many of them actually have it? And what we found was actually, if you screen hundreds of people, there's actually a very small number that do genuinely have encephalitis. And effectively, the number needed to treat is about 4 to 5 cases of suspected CNS infection for every CNS infection there will be in a general immunocompetent population. But that's really important because we know time to treatment improves outcome. So we're going to treat them early, we're going to suspect it early, but what's the pathogen? What's causing the encephalitis? Again, indebted to Nick for this excellent practical neurology article he wrote a number of years ago, when I think he had hair similar colour to this. And it was this great ID mantra which was drummed into me as a junior doctor, and it's really important. It's why did this person from this place at this time get this disease? So let's try and unpack that a little bit. So why this person? So think about the environment they've been in, think about the sorts of pathogens that circulate and why they do. So here's a nice example of the flaviviridae, particularly in this case, Japanese encephalitis virus, which predominates in most of Southeast Asia. So this is an enzoonotic infection, so it's supposed to infect pigs, which amplify the virus. They have a prolonged viremia with lots of virus in their bloodstream. They're supposed to get bitten by mosquitoes to then bite another pig and create that cycle of viral. The virus just wants to keep replicating itself. But periodically, that mosquito might bite a wading bird. So these are sort of wading egrets. And what their job is not amplification. They have actually quite a short viremia. But what they do is they travel vast geographical distances. So they help to spread the virus across different countries and continents. And then lastly is us. We're the dead end host. We don't have a prolonged viremia. We don't travel enough. But when it infects us, it can infect the brain. So the importance here really is an example of how a geographical restriction can relate to a specific pathogen one ought to be looking for. And we have these great maps. This is a nice one that Tom produced a number of years ago, where we can look at the maps of St. Louis encephalitis in South and North America, West Nile virus, which obviously started on the west of the Nile, but has spread to cover large parts of Europe and the US. JE I've mentioned, and as only the Australians could call it, Murray Valley encephalitis in Australasia. So beyond the geographical exposure, beyond the kind of exposure to animals and mosquitoes and other things that could infect us, the other thing we need to think about is the patient themselves. Have they been vaccinated? Now look, many of these causes of encephalitis, this is from my Arin's Lancet paper in 2019, of all of these different viruses, actually look, many of them are vaccine preventable. So JE, mumps, measles, polio, and in fact, some of them, and we'll come to talk about this later, are actually vaccine preventable but not part of routine programs in many countries, particularly varicella zoster, the shingles virus, and rabies. So it's really about thinking about the patient, their geography, their exposure, but also them as an individual in terms of their vaccine status. And why vaccine status is so important is that we know these things work. They really, really work. A very close colleague of mine who's just got his professorial chair spent his entire intermediate fellowship to study Japanese encephalitis and went to India to study it, and it was gone because there was a vaccine program. So, do check out where they've been in terms of their vaccine exposure, because it makes a huge difference. And because these things these things change constantly, there are great resources. If you're in the US, then ArboNet is a great resource provided by the CDC, and it's going to be awesome to hear from Jim Savar later today, who's really at the heart of this. If you're in the UK, we have the UK HSA and Ripple, which is the Rare and Imported Pathogens Lab. Work really, really closely with these people to understand what pathogens are coming in and what your patient is likely to be exposed to. And we have had cases of tick-borne encephalitis in the UK over the last few years, and West Nile is knocking on our shores for certain. Marvellous. So beyond the kind of exposure risk in terms of where they've been geographically, what animals they've been around, what mosquitoes they've had, and what vaccines they've had, there might be very clear clinical features that point you towards a particular infectious cause. Any points for shouting out the pathogen there? Yeah, Borrelia burgdorferi, yeah, Lyme disease, yeah, this one. Varicella, yeah, that's shingles. It's nice dermatomal, it's tracking the nerves, yeah, good. And then I've given you the answers here for these ones. But anyway, so look in the back of the eye, and I have to say, I think this is something that's done infrequently on the standard medical admissions unit, but ought to be done more. So you can see things like cytomegalovirus, varicella zoster, herpes simplex, and toxoplasmosis. You can see really nice retinal changes which will point you towards the pathogen that's responsible. So what tends to happen is you've got the patient in, you've looked at their exposure, you've looked at their risk, you've put them on acyclovir, maybe third generation cephalosporin, and you do a CSF to try and find out really what is the bug that's causing it. Unfortunately, we know that what tends to happen is that the vast majority of patients actually get their lumbar puncture quite late. And we know that things are worse for encephalitis than they are for meningitis. And I know that talking at an encephalitis conference, I'm preaching to the choir, but I'd like you to go back, if you might, and reverberate this amongst your communities, because I think meningitis is at the forefront of the minds of people when someone presents with a headache, altered consciousness, and a fever or febrile-like syndrome. But encephalitis often isn't. And I think we've shown this fairly consistently, that there are delays to suspecting encephalitis, and there are delays to doing the tests that are necessary. And this is the last time I'll promote Nick. This is a great study Nick did about 40 or 50 years ago, where he studied the likelihood of being PCR positive, so detecting nucleic acid in the spinal fluid of patients with encephalitis. And what they showed really nicely was there's this real window here, very early on in infection, particularly after acyclovir has been started, where you're likely to find a bug. So it's really important that we get this lumbar puncture done early. And we looked in a little bit more detail about what that meant for the viral load, and actually the reason these patients become negative is that hour by hour, and certainly day by day, the viral load in the CSF declines, particularly once acyclovir has been started for things like HSV and VZV. And that really diminishes your chance of finding a pathogen. Oh yeah, biofire, right, biofire. So hands up if you see patients who might have encephalitis or have seen a patient. Yeah, lots of hands, marvellous. Hands up whose lab does just bog standard PCR for pathogens. Okay, 1, 2. Hands up whose lab has a biofire. Yeah, more. Yeah, so this is what's happening. So biofire has come in, it's landed, it's with us, we're going to have to deal with it. So biofire is a multiplex PCR machine which allows you, theoretically, to look for multiple pathogens in a single CSF sample, which actually sounds great. You know, you don't have to think about where the patients travel to. You don't have to think about their exposure to animals and mosquitoes. You don't have to think about their vaccine history. You don't have to think about their rashes or what their retina look like. You just send the CSF and it will test for the bug test. Now, the problem is, and this is a great review that came out in 2020, the problem is you look at grouped data, and the grouped data are great. The sensitivity and the specificities are really, really high when you look at a group. But we're not Bentham and Mill, we're not utilitarians trying to do the greatest good for the greatest number. We're Kantians, we're deontological. We have one patient in front of us, and we want to do the right thing for that one patient. And the problem is, the sensitivity is not high enough. It misses HSV1, it misses HSV2, it misses VZV, it misses enterovirus, and it misses Cryptococcus. Now, the problem is, these are treatable. Now, it might be fantastic at picking up astrovirus, or feline tobacco virus, or sarcoma virus, or some other things which are academically interesting, but not going to affect our treatment. So it's really, really important that if you have a patient in front of you whose clinical features, based on their exposure, their presentation, their skin and retinal findings, their vaccine history, if you think that this is likely to be a smaller group of pathogens, test for them directly, and we must not rely on these panels. And the other thing we mustn't rely on is nucleic acid amplification. PCR was fantastic. I remember being around when it first came in. The problem is it's often negative. And it's often negative in patients who have active virus replicating in their brain. Why should what's happening up here inside the brain parenchyma, behind the still relatively tight blood-brain barrier, reflect tiny amounts of nucleic acid we pick up from a lumbar CSF? You make 20 mils of CSF an hour. It's as fast as you make urine. You're constantly washing over your central nervous system. Why should a small amount of stagnant lumbar CSF be an accurate representation of what's happening in the brain? What's much more accurate than nucleic acid, in fact, is to look for antibody production. So it was PHE, it's now UKHSA, but I'm sure there are others that exist in other countries where you have regional or national reference labs. Send your CSF samples for antibody testing, not just relying on nucleic acid. And this is Dr. Reber's formula, but effectively what it's saying is you look at the amount of IgG to a pathogen in the CSF relative to the amount of IgG to that pathogen in serum, and then compare that to the overall IgG in the CSF and IgG in serum. Basically, that coefficient is really a way of just saying, is there intrathecal production of antibody against a pathogen? Right? Now, these antibody tests are great, and I have personal experience of many cases where they were PCR negative, particularly after starting acyclovir, where the diagnosis and the treatment changed substantially as a consequence of knowing there was intrathecal antibody production against pathogen. Right, so we've all agreed we're going to get CSF. Day 1, hour 1, and then annually or hourly until we get a diagnosis. The other thing that can help somewhat is MRI features. So here's some MRI examples of patients with different forms of encephalitis. These here are, so this one is a very typical HSV encephalitis case here. You can see this bilateral but asymmetrical temporal lobe involvement. Here, as Sir Ross will talk about, is the arrows have moved, but it's obviously the white bits. A fairly symmetrical but much more subtle limbic encephalitis. Here you can see on the diffusion imaging, and then the top images are various flaviviridae affecting the basal ganglia. So the MRI can be helpful. But of course, MRI is not available in many of the countries where these patients are affected. And not only is MRI not available, just neurologists aren't available. And the only reason this slide is up is to maybe be a call to arms to those of you that work in very well-resourced settings to think about, if we really do care about encephalitis, maybe one of the biggest differences we can make is to spend a bit more of our time and a bit more of our efforts in those areas where there's the greatest burden. All right, so the last test I'm going to talk about when it comes to infectious encephalitis is EEG. So this is what I was taught. that periodic lateralizing epileptiform discharges are diagnostic of herpes simplex virus encephalitis. Absolute nonsense. They're present in metabolic disturbance, they're present in alcohol intoxication, they're present in coma. They are not useful whatsoever. So they were dumped out of the UK guidelines really for being useful at all. But actually where EEG does have a real use in encephalitis is conditions like this. So this is a young man I saw in Lusaka in Zambia. So he's a young man, he's in a coma. He's not had a lumbar puncture, there's no CT scanner, let alone an MRI scanner, and they don't know why he won't wake up. But you go and you examine him. Does anyone want to comment at all about what they can see on that short video? Just say what you see. It's like Mr. Chips. Go for it, great. Marvellous, yeah. So some clonic movements of the first toe. Perfect, good, all right. And then if you watch that patient for a little bit longer, actually he starts to posture that whole leg and have movements there. So that's a figure of 4 posturing phenomena. So this poor young man is actually in subtle motor status epilepticus, and that's why he won't wake up. And that's really, really important because we've talked a lot about trying to find the pathogen that's causing the encephalitis and how to treat them. But actually the complications of encephalitis are important too, and seizures is arguably one of the most important and can easily be missed. Now, if we look at just our region in the northwest of England, we looked at a few hundred people who'd had EEGs requested by neurologists for suspected non-convulsive status. The most common cause of non-convulsive status epilepticus was actually encephalitis, which is obviously incredibly treatable. Marvellous. Okay. So I will start to draw things to a close as we just talk about the infectious patient with encephalitis who's not improving. So you started broad spectrum antibiotics, you started antivirals, you've done your lumbar puncture, you've done your MRI, but they're not improving. Now, if they've got a proven pathogen like HSV, we know that mutations are really, really common, but mutations resistant to acyclovir are really, really rare. So it's probably not going to be resistance. It's probably going to be seizures or edema. Now, when it comes to seizures, the mechanisms which drive these seizures are still really poorly understood, and there have been no randomized controlled trials to look at how we should treat these patients. Greta, who's a member of my team, did some great work looking at different cohorts of patients with encephalitis to really try and pull out what features would put you at risk of having seizures. And it was, regrettably, antibody associated was quite important, but HSV is what we're interested in. It would say HSV, abnormal Glasgow Coma score, and an abnormal EEG. So these things are really important. So if you've got a young person, particularly a patient with HSV encephalitis, particularly if their coma score is not normal, and they're fluctuating in their coma score with or without focal motor movements, do think about whether an EEG is helpful because they may well be in non-convulsive status epilepticus. And the area under the receiver operating curve was actually very, very high for these sorts of models trialed across 2 cohorts. And now working with Thomas, who's a new member of the team, we're actually applying this risk score in several thousand patients from around about 30 or 40 different countries in the world, really trying to create basically a GCS for seizure risk in this population. And we know it's important because it affects outcome. Right, so if they're not improving, it could be the seizures. If they're not improving, it could be resistance, but probably not. But it probably is edema. Now, we know we've all had patients who are in the intensive care unit and their GCS is dropping and they become intubated and ventilated, and you're thinking they're on acyclovir, there's nothing else I can do. And we know these patients ourselves, right? They have these huge volumes of temporal lobe edema. It's directly adjacent to the brainstem. It causes brainstem compression. And here's an example of one of really severe cases. So here's a young boy, he comes in, his CT looks fairly normal. You could argue perhaps there's a little loss of grey-white matter differentiation there on the left, but here on his second scan, it's very clear. There's a lot of left-sided edema causing midline shift, effacement of the sulci and compression of the lateral ventricle. And here, the encephalitis becomes so severe, he's actually completely blown his skull straight off his head. No, the surgeons. So we had a decompressive craniectomy that removed a portion of his skull to allow the brain swelling to happen. And I'm delighted to say he survived all of this and is now back to boxing, rightly or wrongly. So what should we do? I mean, we can't take the skull off everyone. I remember vividly having stand-up rows with my neurosurgical colleagues in clinic between patients, screaming at them they must simply take the top off this egg that was swelling in ITU because I'd given them acyclovir. I had nothing else in my arsenal. What should I do? Please, please do a decompressive craniectomy. And they'd always come back saying, well, we can take the skull off, but then what do? We bury it in the peritoneum. We then have to reinstall it. They get infection after infection. They get CSF leak after CSF leak. Do we really want to do this to someone? Is there really nothing else that you can do? Now, the question has been for the longest of times whether we should use steroids. And it's really exciting that we're going to hear from Tom Solomon this afternoon about the results of the first randomized controlled trial of the most common cause of viral encephalitis since Richard Whitley's trial in the 1980s. And that's where the steroids work. My argument has been for a little while that they might be helpful, but we're not sure, and maybe they're a sledgehammer to crack a walnut. And I shall just draw things to a close by saying a little bit about the science that underpins this. So I looked back during my PhD and my ACL at what the inflammatory processes were that were driving brain inflammation and encephalitis. And I looked at the amount of albumin in the CSF and the blood, just like I mentioned before, which tells you how leaky the blood-brain barrier is. I looked at the swelling on the MRI scan, which tells you how much brain edema there is. And I looked at the patient's status in terms of their coma and their outcome. And what we found was that actually it wasn't just one mediator that was important. It was actually the balance between the pro to anti-inflammatory mediators, so the IL-1 family versus the IL-1 antagonists. So that's IL-1RA and IL-10. But so the agonist versus the antagonist in terms of this pro and anti-inflammatory balance that was responsible, or at least correlated with, blood-brain barrier breakdown, cerebral edema, and how the patient did. Now, really to study this to get at the mechanisms to find a targeted treatment that would stop the blood-brain barrier breakdown, stop the edema, but not license uncontrolled viral replication, would require a model. So I spent a while in the US building this model. So this is a black 6 mouse. So this is a lysine GFP mouse. So the green things you can see are neutrophils. So this is, I've replaced the skull with glass, and I'm using multifocal and intravital microscopy to look at the brain in real time. And there's an intravenous Q tracker, which is red. So here you're seeing the postcapillary venule. This is the vein in the cortex of a mouse who's anaesthetized. And then in response to HSV infection, you can see this marked transendothelial migration of these neutrophils out of the blood into the brain. And it took a lot of work and a number of years, but we were able to identify the receptor that was driving this, CXCR2, so a receptor on the neutrophils. And if we knocked that out, either by using monoclonal antibodies or by using mice which were deficient in that receptor, although infection induced all this recall of neutrophils towards the blood vessels of the brain, even though they were able to roll and crawl and sometimes adhere to the blood vessels, they couldn't migrate into the brain and they couldn't cause blood-brain barrier breakdown. And these mice were prevented from having severe disease. And here's an example of an individual fellow I saw about 3 o'clock in the morning in Boston. You'll see this little chap here. He's actually already in the brain. He's in the Virchow-Robin space outside of the brain. So he's between the blood vessel and the brain parenchyma. And you see he crawls around, and then periodically you'll see this red splurge. And what that's happening is that's actually breakdown in the blood-brain barrier in real time. And we've done a lot of work subsequently, and it looks like this process of netosis and degranulation is a really important part. And it may well be that targeted therapy, which focuses on trying to ameliorate those aspects of the immune response which cause brain edema, whilst leaving those aspects of the immune response which control viral infection alone, is where we need to go, but we will see. And that's sort of how it happens. And then the very last thing, before my thank you slide, is to say, even beyond viruses in the brain, the really, really exciting work, in my opinion, that's happening right now is how viruses and other pathogens outside of the brain can induce inflammation inside the brain. Now, we're very happy with acute respiratory distress syndrome, ARDS. So this is like a massive pulmonary inflammatory syndrome, even if there's no pathogen in the lung, right? ARDS has been recognized for decades. But there is a brain-related inflammatory disorder syndrome, or a BIRDS, if you will, where you don't require pathogen in the brain, but it is yet pathogen-driven that induces this inflammatory response in the brain, which is manifest as cognitive dysfunction, as coma, as seizures, and as microglial activation histopathologically. So, in conclusion, suspect it early, always suspect it. I know you believe in encephalitis, that's why you're here, but please disseminate this message. And you have to investigate 4 or 5 people for every one you'll find, and that should be expected. We do ECGs on a lot of people with chest pain that don't have a heart attack. Think about where they've travelled to, think about their vaccine history, because vaccines can prevent an awful lot of these conditions. There are some clinical clues based on their geography, but based on their clinical features, their dermatological, their retinal, and other features. When it comes to investigations, yes, investigate them early, but think about the timing, particularly not just relying on PCR, and really particularly not relying on multiplex PCR like the BioFire, and think about serological investigations and the role that imaging might support you with. And if the patient's deteriorating despite best treatment, think about those 2 really major complications, seizures and edema, and think about emergent phenomena, as we've all learned from COVID. Thanks to a wonderful team that make all of this possible. I would do none of it without them. And thank you for your time.
So I think we have some time for questions, and I have an iPad here for online questions. So if you're not within the lecture theatre, do ask questions online. But from the audience here, any questions for Ben after this fantastic talk through infectious encephalitis? At the front there.
Thanks very much. It's a really, really interesting talk. On the timing of CSF testing, I think on Nick Davies's paper there was a higher yield at 5 days, and then some of the sort of PCR yield data, it was higher earlier. What would you recommend in practice? What does the evidence say about A, the optimal time to test, and B, how often should you retest if you have a high clinical suspicion?
Yeah, thank you. So the question was, when should you test and when should you retest? So the problem with encephalitis, I think we'll all agree, is the onset is insidious, right? When does the flu-like illness become the headachy illness, become the confusion that results in them being hospitalised? So actually having a hard time on knowing exactly in hours or minutes where one should test is actually probably impossible because of this insidious onset. That being said, I think what we would argue is that whatever got them into hospital is the point of sufficiency. That could be acute confusion, it could be a seizure, it could be the severity of the headache. But at that point, we should test as early as possible, because that first CSF is most likely to be unadulterated by antivirals and antimicrobials. So we really ought to just get the ASAP. So that's the simple answer. The question is when to retest. Now, it's highly unlikely that a patient would have a pathogen causing encephalitis with 2 negative lumbar punctures separated by 48 hours and a normal MRI scan. So I think a reasoned argument would be LP ASAP, particularly if you can do it before they start on antimicrobial or antiviral treatments. If it's negative, then repeat after 48 hours. But thinking particularly if there's been a prodrome and if they're PCR negative, but their MRI looks suspicious, get the serological testing done. I mean, in fact, I'm a patient in ITU right now who is consistently PCR negative for HSV, but has disseminated HSV encephalitis for the third time, who is antibody positive on CSF but PCR negative because of the amount of acyclovir they've received. And I think we've become PCR reliant as certainly in the UK, interested to hear what others think, but certainly in the UK, PCR reliant, and we need to think a bit more about CSF antibody testing.
Great. Sir, can we have a microphone? Thanks, Selena.
The ARDS-like syndrome that you talked about in brain, how is it different from the encephalopathy that we see in sepsis, or for that matter, dengue encephalopathy and so on? Is it really different, or it's another extension of it?
It's a great question. Would you like to sit on the MRC panel that's reviewing our grant? So we think it's probably an extension, actually. We don't think it's unique. We think that it's been under-recognised. I think we've made a slightly false dichotomy between encephalitis and encephalopathy based on the itis phenomena. Are there white cells in the CSF? Is their MRI abnormal? And I think, as we're about to hear from Sarosh, in many of the cases of what we agree now is encephalitis, the CSF is quiet. The MRI is often normal. And I think the Overton window on what we mean by encephalitis and what we mean by encephalopathy needs to be expanded for exactly that reason.
Questions over here.
Thank you. I was just wondering, in your experience, how often is it that you see infectious encephalitis without the presence of fever or raised inflammatory markers? Because often we are asked for an opinion about patients who have confusion, and there isn't sort of an obvious other cause, but they don't necessarily have a raging fever or a very high white cell count. Do you think it's still worth us investigating and treating for viral encephalitis in that situation? I just wondered how often it happens that those cases turn out to be infectious.
That's great. Thank you very much. My plant in the audience has asked the question I was hoping for. Excellent. Yeah, so I mean, if someone presents with a fever, people think infection. If they present with brain dysfunction, eventually they do think it's brain fever. But the problem is when they don't have fever. That's your question. Now, even in HSV encephalitis, even in the most common viral encephalitis, about 10% of people at least will not be febrile on admission. So that's why we would always couch it, and in the national guidelines do as well, couch it in the context of a fever or febrile prodrome. So if someone says they've been fluey and feverish at home, it doesn't matter that when the nurse measures their temperature, they don't measure as pyrexial. This is not sepsis. In terms of inflammatory markers, the CRP and ESR might be normal or near normal. This is a brain inflammation. This is not sepsis. This is not meningococcal septicemia. This is viral encephalitis. There's no reason they should mount a systemic inflammatory response. But the last answer to that point is fever should not be what pushes our threshold for should we treat, should we investigate. The single greatest investigation you have, second only to a lumbar puncture, is this. Call their wife, their husband, their boyfriend, their girlfriend, their partner, their roommate, their sister, their brother. Are they being normal? That's it. If they say, you know what, he's being really weird, he's normally completely fine, but he keeps obsessing about the fact he can see WhatsApp messages coming through his brain, or he thought that the newsreader was talking to him about causing the weather. Right, that is much, much more sensitive than a one-off temperature measurement in a temperature that fluctuates minute by minute, hour by hour.
So we've got one online question here, Ben. I don't know who it's from, but they were saying, I was wondering if there was any research looking into what makes a person more susceptible to herpes simplex virus specifically. Does a previous history of STIs or other minor HSV infection make one more susceptible to it?
Well, to the cold sore sufferer online, you need not worry. The very fact that HSV encephalitis is as fortunately relatively rare as it is, means that when we get clusters in families, we do study them. So there's been great research where you've had, you know, a brother and a sister, or a brother and a mother, or a brother and an uncle, who've all had HSV encephalitis. And when we look at their immune system, they do have defects, particularly in the toll-like receptor region. So this is something we inherited back when we were flies, I think. These are receptors which pick up viruses. They're able to detect viruses replicating in the cytosol. So they detect virus and they produce this TNF-alpha-driven interferon gamma response, which keeps viruses in latency. And there are these mutations that are out there that exist, which make you at high risk for encephalitis. But as to why the general population, as to why the fact that all of us, well, let's say not you guys, but everything from there to there, probably have got HSV resting in your trigeminal ganglia. It's just resting there latent, and probably everyone from there to there have got it resting inside neurons inside your brain. When you die of your stroke or old age or diabetes or whatever it is, if we were to do a post-mortem, you will all have HSV in your trigeminal ganglia in your brainstem, and you will all have HSV inside, HSV inside your brain without causing any disease. So why on earth does it cause disease in some people and not in others is an excellent area of research, and an area of research I hope will keep me going until I have the resplendent white hair of our chairman.
Other questions? Sorry, sir.
Hi, thanks for the great talk. So towards the end of the talk, you mentioned the scenario of having a neuroinflammatory process even before the pathogens enter the brain. So do you think that this will happen in response to, for instance, inflammatory cytokines that from the blood they can pass the blood-brain barrier, or rather microbial components that are released from the pathogens in the blood and then can enter the brain? And also, what do you think are the very first cells in the brain that trigger the neuroinflammatory response? Are the pericytes, microglia, or astrocytes?
Okay, so two questions. The first one's straightforward. Yes, I think it's soluble inflammatory molecules, probably cytokines, maybe complement, that drive the initial inflammatory response. In terms of what starts things first, so I had 3 big grants arguing that microglia would be the problem, and they funded me because it made sense, right? You're looking for an immune response. These are the immune cells of the brain. Surely it's, you know, here's the culprit. But anyway, since we did the work, it's not. It wasn't microglia. It was actually perivascular astrocytes, which form this kind of wonderful interface at the neurovascular unit between all the inflammatory processes of the bloodstream and the brain. You know, we always think about astrocyte foot processes, these podocytes, you know, these gatekeepers to the brain. It turns out they have an immense capacity to produce inflammatory mediators as well, particularly chemokines, and probably have a really critical role in regulating which immune cells can and can't enter the brain in specific conditions. So, yeah, I was wrong. It was astrocytes.
Thank you very much.